Got some disagreement. I need someone to speak up and be definitive. The skull. All right, we're gonna. I did draw that. Yeah, I working on my artistic skills as I go through this chief year. I need some long-term skill when it's all said and done. Okay, so this gentleman is currently at the university right now. This is going to be a little bit long, but he's a 71-year-old man with HCV cirrhosis post a liver transplant in 2004, kidney transplant in 2020. He's had recurrent UTIs. He had a sinus surgery in January for chronic sinusitis at the VA that was uncomplicated. He has a bunch of other risk factors. Came in with hematuria initially. He was treated for a UTI. He had a cysto and a clot evacuation on day 3. He had a nephrostomy tube placement on day 5 and had a renal pseudoaneurysm injected with thrombin. Day 12, a stroke alert was called because he had difficulty following commands. He was disoriented. The team thought that he probably had sepsis or some sort of bleeding issue, but he did have a new focus of hypodensity in the right subcortical region. Overnight, he got worse and he was transferred to the university for further management by surgical specialties. When he got to the U, he had an IR procedure for an actively bleeding pseudoaneurysm of 2 renal transplant arteries. And then after that, though, he remained altered when he rolled back to the surgical trauma ICU. So we're sort of picking him up the same place the STICU picked him up. Altered man, not yet intubated, sitting in the ICU with that prior CT head. So this is an ID conference. So what do you guys think with this history, just really quickly, like what's sort of going through your mind? Deafening silence in the room right now. Sure.
Are we missing a source of meningitis?
Great. So Katie brings up, are we missing a source of meningitis? So is this something like intracranial? Perfect. All right. It can only be meningitis. I think probably right now you're trying to reconcile like why I drew a skull and then I just talked about a bunch of renal stuff, which I think is pretty fair. So this gentleman gets a CT head and the CT head immediately recommends MRI. So here's his MRI. Let's take a look. This is going to be first is T2 flare images. So on T2 flare, your CSF will be what color? Anyone know? Find out soon enough. So your CSF on T2 flare will be dark. So T2 flare makes the CSF dark and it makes pathology white. And so now that we know that, let's go back and you're looking for white things on this image to indicate pathology. Does anyone notice any abnormalities? Parissa, we'll play it one more time and then Parissa, say out loud what you just said again. Yeah, what about his sinuses? Yeah, so his sinuses look bad. Completely agree. So what you're seeing there is something in his sinuses. All right. So now let's look at a T1 image. So T1 images will the pathology will now be black. This is with gadolinium. So Parissa's worried about his sinuses. Let's see if that same thing still pops up. And not great. All right, so what do you guys think that is?
Is he immunosuppressed?
Is he immunosuppressed? I'll defer that question to you guys. What do you think?
Yeah.
Yes, he is definitely immunosuppressed because of his transplants. Is this mucor? Who said that? Parissa, why do you think this could be mucor? Great. So trying to tie together like a aneurysm, like a vascular issue with something in his sinuses. That's perfect. So what did the official read say? Is Parissa bound to be an official neuroradiologist? And yes, so their findings were consistent with invasive sinusitis with destruction of the ethmoid osseous septations. I'm not going to read this whole thing, but that is way more stuff destroying your sinuses than you want on your average MRI. And then the thing that Parissa called attention to is a 7mm rim enhancing collection with direct inspection. It's going into the left orbital apex. It's got right frontal edema, and it extends into the nasal bridge. So overall, pretty bad. And Carissa, say it one more time. What was the thought at the end of this? What was the leading differential? Great. So because of this man's renal transplant history, his liver transplant history, they thought this is mucor until proven otherwise. So ENT was consulted, and ENT said, yep, we will take him to the OR. So for those of you who are eating right now, I'll give you a fair warning. ENT took pictures. And that, I don't know where in his sinuses that is, but that is within his sinuses. And what you're looking at is a purulent exudate with that throughout his sinuses. And so ENT saw this basically everywhere with their scope and debrided and opened it up. You just linger on that for a second so we're all appropriately disgusted.
Mucor usually black.
Yeah, great, Mike. So Mike brings up a great point that mucor is usually black. And so how do we reconcile mucor being black with purulence throughout his sinuses? It is.
It's not mucor.
Is it not mucor? Great. So is it actually mucor or is it something else? What else would you guys add to your differential for this possibly mucor thing? You said Acinetobacter?
Acinetobacter. I didn't know how to say it.
Someone said Aspergillus. Why Aspergillus?
I just know that it's supposed to be very invasive in a way similar to mucor.
Great. So thinking about invasive fungal stuff. Mike brought up, could this just be a run-of-the-mill bacterial infection? Perfect. All right. So let's actually get the final, just because you don't often see a lot of ENT op notes, but this attending really went for it, so I have to acknowledge that. They did a sphenoidotomy, ethmoidectomy, sinusotomy, and then in red is the amazing sentences that you never want to see in an op note. But it was clear both on imaging and as soon as we got a little further back, the skull base was indeed gone. So this man is operating without a skull base and has an invasive and erosive process, intracranial infection ischemia, and chronic rhinosinusitis.
What follows the pulsatile?
Oh yeah, so
Pulsatile, I want to know what that is.
yeah, I cut it off before. Dr. Happy brings up the pulsatile. I cut it off before that. They saw something pulsating, which they thought was either his brain or a intracranial vessel. So they tried not to touch it. Yeah. All right. So right now we're thinking this is mucor until proven otherwise. And what do you guys want to do next? We need to actually find out a culture here. So we send this to the lab. And here is the pathology final diagnosis. Fragments of bone and soft sinonasal tissue with acute and chronic inflammation, fungal hyphae are present, histomorphology consistent with mucor. So take about 30 seconds or so at your tables, or a minute, and I want you guys to think about, now that you know this is mucor, how do you want to treat it? All right, let's come back. Who feels brave enough after their 30-second to a minute up-to-date search? How do we treat mucor here? Amphotericin, great. So why are we jumping straight to amphotericin? All right, yeah. Great, you want to cover mucor. And so Kate's exactly correct. So this is a pretty simple question. If you are concerned about mucor, you should immediately start amphotericin because it is probably one of the only antibiotics that has pretty definitive coverage for mucor. problematic because amphotericin is a tough drug to tolerate, but you want to start amphotericin. So this patient gets started on amphotericin, and 2 days later, a culture comes back, the sinus culture from that same operation, which does not show mucor, but shows rare Aspergillus species, which they say is consistent with Aspergillus flavus. So at this point, this gentleman is on amphotericin, but now has a culture showing Aspergillus flavus, and there's also a concern that he may still have mucor. Do we need to change our antifungal regimen? All right, who votes in the room? Who votes yes, you want to change your antifungal regimen? Apoorva does. Who doesn't want to change their antifungal regimen? All right. A lot of people abstaining, except for a couple people at my table. Apoorva, why do you want to change your antifungal regimen?
I had a patient with what we thought was invasive aspergillosis, and we used voriconazole.
Great.
That's what other users.
Why did you, do you know why you used voriconazole? So the reason you use voriconazole is this study from 2002, which they compared amphotericin to voriconazole for people who had invasive aspergillosis. And what they ultimately found was the cure rate for voriconazole was about 50%, and the cure rate for amphotericin was about 32%. So since 2002, we've been recommending voriconazole over amphotericin for people who have invasive aspergillosis as primary therapy. But you also should not stop the amphotericin because voriconazole does not have great coverage for mucor. So let's just take a step back, make sure we're all on the same page here. Aspergillus and mucor. What are our risk factors? Like, why did this person get it? Great, so he's immunosuppressed, and then someone just call out, how is he immunosuppressed? Like, what is the thing? Great, so he's transplanted. So if you are transplanted, you're immunosuppressed. Great, diabetes. HIV, perfect. Acutely ill with a UTI. Oh, this gentleman, yeah. So if you're acutely ill or critically ill, you are certainly higher risk. And then the last one, I'll throw that in the HIV, is neutropenia as well. Is going to get you a risk factor for both of these. Interestingly, so diabetes, which one of these is diabetes more associated with? If I was asking a step 1 or step 2 question. Yeah, so diabetes is going to be more associated with mucor, and sort of other forms of immunosuppression are going to be more correlated with aspergillosis. So if you were taking step 1 or step 2, keep that in mind. Probably doesn't matter so much in the real world. All right, so treatment, you guys are exactly correct. We want to start amphotericin if we're concerned about mucor, and you want to do voriconazole if you're concerned about aspergillosis. What side effects do we have to watch out for amphotericin? Hypokalemia, great, so low K. Awesome. Low mag, I like it. The students who recently took step 1 are crushing this right now. Yeah, sure. I think that's it. And then what else does it cause? Why do we run it slowly? Why are we always concerned about giving this? Nephropathy, great. Yeah, so it's going to cause renal failure in some people. So it's really hard to tolerate this medicine. Great. Voriconazole, side effects? Vision changes, perfect. So vision changes and specifically hallucinations are a big thing that people talk about. It does prolong your QT. It also causes osteitis, so it causes bone pain. And then you also can't let these people go outside because it causes, I'm blanking on the word now. Photosensitivity. Thank you, Dr. Fainstead. Photosensitivity. So similar to doxycycline, if these people go outside, they will burn. All right. So any questions about Aspergillus or mucor? So how does this case end? Interestingly enough, University of Washington does a universal PCR on infectious stuff to make sure we were treating the right thing. So they sent this off to the University of Washington, and they found that Aspergillus flavi was detected, but no Zygomycetes, which is the mucor genus, was detected at all. So from this, they actually concluded that this person ultimately had purely aspergillosis. So they were able to stop the amphotericin and treat him purely with voriconazole for his aspergillosis.
How long did that take?
Great question. He's going to be on therapy for a while. So he has no defined endpoint because he's not a surgical candidate, but a while.
And you can just send anything to University of Washington, they'll just run all the infections
Yeah, you
off.
just put it in an envelope and say to you,
You're just
Doug,
like,
and just
you
push
have to
it
sell
in
this
the
guy's
mail.
Skull base, just check it for all the stuff.
Yeah,
How
so
that works?
yes,
How
they
does it work?
they apparently ran just a PCR panel they have for a bunch of different fungal, bacterial, and they have viral stuff too, and they will tell you whether it's detected. And so if you have no DNA detected in your entire surgical sample, the chance of having it is almost zero.
Is this a pyroFire?
This is not. I think this is their own specific thing. Yeah. All right. So the last thing, which some of you may have seen in the news, why did I bring up Mucor today? Is because Mucor is unfortunately back and pretty bad in India right now. So there's sort of an epidemic of Mucor affecting COVID patients in India. Dr. Heppy, Dr. Fain said, do you guys know why they think this is happening?
You know, the two things that I read, two theories are, one, so the climate is much more predisposing to Mucor. It grows much better in like hot, humid environments. So like it's around more, I think. There's more of it around than there is just living in the environment than there is here in, at least in Colorado and most parts of the US. And second, there's some conjecture about, you know, all the steroid use with the coronavirus. So that's just, to my understanding, it's pure conjecture.
Great. So if you have a COVID patient here who's been in the ICU for a while and higher risk for Mucor, please keep this in mind.
And, you know, I didn't see any details on cases of these like prolonged intubation, patients, like the critical illness, all that stuff.
Cool.
Well, and Danny, this is Mark Kern. Some of these concerns came up stateside in the Covacta trial, which was the first trial looking at tocilizumab. It looked like there were increased rates of aspergillosis, invasive aspergillosis in COVID patients. So.
Awesome. Thanks, Mark. Have you guys seen any of this at Denver Health?
We have not, thankfully. No, it's been a couple of years since I've seen a Mucor case.
Great. Awesome. Dr. Kearns for the students is one of our ICU attendings over at Denver Health. All right. So first case, knocked out. We talked about the skull. This person ended up having invasive aspergillosis of their skull base with a concern for Mucor. So knocked out 3. Do you guys want to go 1 or 2 next?
I have a question about 3. Did he need to have his skull? Like, do you need any interventions for how much of it's gone? Or?
No, he did not. He did not need a further resection. He wasn't a candidate for a further resection, but he did not apparently need one or was not recommended for one. Great question. So that gentleman is actually discharged to hospice, but then decided he wanted treatment and came back. So he's back at the U getting treated now, and they think his prognosis is actually slightly better now that it's aspergillosis versus purely Mucor. So, but yeah, quality of life is not great. There'll be a theme in this conference that a lot of these cases don't end well. None of them end well.
Do you have to look at people's livers, like if they have aspergillosis, is there like some follow-up they need for HCC?
Great question. Is there follow-up attendings? Is there follow-up for
I'm not sure.
aspergillosis?
Like aflatoxin, like a risk factor for
Oh, good question.
thyroid carcinoma?
Wow.
I'm not that familiar with like off the top of my head. Yeah.
I'll find out. I would have
We treated a ton of aspergillus and, you know, and I don't remember that being discussed, but I want to know if it's true.
All right. Case 1 or case 2?
But to answer that question, for pulmonary invasive aspergillosis, it's going to be serial imaging to ensure that the lesions are responding to treatment.
Gotcha. So serial imaging for pulmonary and presumably serial imaging for all people who have invasive fungal infections, especially aspergillosis. Great. I'm glad Dr. Kearns is on because the last 2 cases are both from Denver Health, and I think he actually took care of both. So we're going case 1 next. Is that what we decided? All right. Case 1. So you've got a woman with a month of on and off fevers, cough, diarrhea, and vomiting. Hasn't been evaluated for these symptoms and has had recent travel to Mexico. So keep that stem in mind. Here's her HPI. 24-year-old woman with HIV. She is not on ART for 8 years. She has fatigue, night sweats, chills, a cough for a month, and a 30-pound weight loss. She was diagnosed with HIV peripartum 8 years prior, not really ever on ART. Splits time between Mexico and Denver. She's never had any HIV complications, and she's got no other risk factors for TB or other infections besides the HIV. She's very febrile. She's got a heart rate of 128. Blood pressure is low. She's satting 93% on 2 liters per minute nasal cannula. So take about 30 seconds to a minute at your table. And when we come back, I want like top 3 differentials for what is infecting this woman. All right, let's come back. How about middle table, Katie and co? What were you guys thinking?
We had under TB, histoplasmosis,
What was the last one? Toxo. Great. So thinking like HIV, disseminated mycobacterium, or fungal disease. Perfect. All right, let's get some more information here. TB is the right thought here initially early on. So this is her initial exam. I will just point out to you guys the abnormality here. The really only abnormality besides the fact she looks bad is that in her mouth she has small scattered white plaques on her soft palate. Not super surprising given we know she has HIV. But knowing that, what do you think her CD4 might be? All right. The room is murmuring 10. People are throwing out numbers. The room is murmuring, but positive murmur sign. No one thinks it'll be high. And then she otherwise like just doesn't look well. Okay, so labs. Let's take about 30 seconds to absorb those labs here. I've put in red everything that's abnormal. For the students, the 6.9 is a hemoglobin, the 18 is a bicarb, and the red things in the vertical fishbone are her LFTs. All right, do these labs get us any closer to figuring out what type of infection this woman has? CJ, you're looking at Apoorva and making a thumbs up sign. What do you?
I think LDH can be high, PJP, but it's not like that high, so I don't know if I can take any away from any of this.
Yeah, great. So, and why might those point you to histo, Katie? Great. So elevated LFTs might point us towards histo or something affecting the liver. CJ correctly pointed out that an elevated LDH is associated with PJP. And so these labs are for hemolysis and for concern for PJP. And then, right, the lymphopenia and the sort of white count itself might be explained just by her HIV, which we know from the CD4 is not currently well controlled. Okay, so you see these labs.
It's a great point that CJ makes, but one thing to highlight is lots of infections can make your LDH mildly elevated. Like oftentimes you get a disproportionately elevated LDH in PJP, but you could see this in strep pneumo or any number of other infections, like to the degree of her elevation.
Awesome. Thank you, Dr. Kearns. So what do you guys want to do next in terms of diagnostics? Great. Don't overthink it. Chest X-ray. So here is her initial chest X-ray. So we'll say take about 30 seconds to a minute, and then we'll have one of the interns in the room give us a synced read of this. All right. Can I have a brave intern volunteer to give me a succinct read of this X-ray? If no one volunteers, then I got to pick someone, which is weird. All right, Apoorva, just because you're on my team right now, and I know you can read X-rays. What do you make of this?
So it's a very abnormal these like in between reticular and alveolar infiltrates, and then we noticed on case complications left, there's kind of this like area that's darker that seems like it could possibly be a cavitary type lesion. Or sorry, disease frame.
Are you pointing to this area down here?
Yeah, we didn't know what to make of that.
Yeah, and why did you say this could be a cavitary lesion?
It just looked darker than the rest, so I thought of air.
Great, I like it. So like the rest of her lungs, like Apoorva correctly pointed out, have this like reticular, alveolar, nodular appearance, but that one area looks a little bit darker, and there is this like sort of darker spot right in the middle there. Excellent read. Apoorva, is this enough for you to get a CT chest?
Yeah.
Great.
I feel like I probably would have had low thresholds
Yes, agree, Katie. So we're gonna do two views here. This first view is gonna be her mediastinal windows. We're gonna play this once, and then we'll do the lung windows. This scrolls quickly, but just yell out when you see the abnormality. So Apoorva, does this fit with what you just read?
I guess I would expect, I guess it's not the lung field, so I would expect there to be even more, but yeah, that right there definitely looks cavitary.
Awesome. So Apoorva had a great read and has correctly pointed out that before we even see this person's lung fields, that they have a cavitary lesion in the right lower lobe of their lung with a pretty large air pocket in the middle. All right, so then we get the lung windows. And we'll play this twice. And again, just call out abnormalities as you see them. So this is bad. We'll play it one more time. All right, so what abnormalities are you guys seeing? And just in terms of the imaging, you don't have to put a name to the diagnosis, but what does the imaging itself look like? Miliary, great. So Parissa has thrown out the word miliary, which is correct. Radiology used this as well. What else do you see on here? You've got the cavitary lesion that Apoorva correctly pointed out. Mike's pointing out that you see some ground glass as well. Awesome. So you see fluid in the fissure, or you see septal thickening. Perfect. Are there air bronchograms? Probably, yeah, right there in that lower lobe. You can see some air bronchograms as well. Dr. Kearns, I think you might be driving, but any additional thoughts on the CT?
No, I think that's a very nice description. I mean, I think the takeaway that I want people to notice is like how nodular it is. Like, and what you can't tell on the plain film, I would have told you that the clinical syndrome, in addition to the cavity that Apoorva wisely pointed out, is that that patient had ARDS because they had a bilateral infiltrate and were quite hypoxic. But, what's a little unclear to me is whether it truly is miliary, because miliary is like sort of randomly distributed. It's like sort of something shows up and gets spread through the bloodstream, like, and gets scattered all over, and everything is the exact same size in theory. Where this, like, a lot of it is sort of perilymphovascular, like, so it looks maybe a little different than some of the classic miliary pattern, but again, not a chest radiologist.
Awesome. Thank you, Dr. Kearns. So final CT read here. Right lower lobe consolidation with central multiloculated cavitation, pulmonary nodules, aggressive pneumonia. They gave the differential that you all gave right off the bat. They have some hypoattenuating hepatic lesions as well, to call out Katie's point. Malignancy is less likely, and then enlarged lymph nodes, not surprising. Okay, so take about 30 seconds, and I want you guys to tell me what other labs you want to send off right now in terms of micro. Like, what other micro tests do we need?
People are thinking about that, Danny. The question I would ask is, could this be TB? Because it's in the lower lobe.
Yes, great. And then Dr. Kearns' point, could this be TB? All right, let's come back. So broadly speaking, what test do you guys want right now, micro or otherwise? Blood culture is great. AFBs, MTB, you get all of that. So here's your initial workup. COVID negative, malaria smear negative, blood cultures negative, AFB sputum negative, pneumocystis negative, fungal blood cultures are initially negative, strep pneumo and Legionella urine antigen is negative. And then at that point, the patient is bronched by Dr. Kearns, actually, I believe. And on the bronch, they send the fluid off to pathology afterwards. And pathology reads this: innumerable yeast forms consisting of large spherules, the majority of which show endospores. Special stain highlights these again. Histologic experience most consistent with coccidioides. So, Dr. Kearns, if you're available, why did you decide to, the concern for cocci was pretty high initially. Why did you decide to bronch and send for this as opposed to waiting for the blood test?
Well, so first and foremost, I mean, we put the bronchoscope in right after we intubated her, like, just because her degree of immunosuppression, she easily could have had 2 or 3 different things happening simultaneously. And with a differential so broad, like, bronchoscopy was going to be the way to get the answer most expeditiously. Like, and to go back to the concept of TB, which obviously she was at great risk for. She was a native of Mexico and went back and forth very routinely. Is that folks that are immunosuppressed in children, oftentimes with their TB, it will be lower lobe. It won't respect the thing that you've been taught about it being predominantly an upper lobe disease. So because of the concern for endemic fungal, and again, where she lived in Mexico, cocci being a higher risk than histo, that's why we did it right away. And we actually sent it for cytology because sometimes you get that information back faster than the cultures, which takes some time to grow. So we bronched her on Thursday morning at like 7:45 a.m. and by Friday afternoon at like 2, we knew that she had cocci.
Awesome. Thank you, Dr. Kearns. So to Dr. Kearns' point that he got it back faster, these 2 cultures, the bronch culture and the blood culture growing mold, took 5 or 6 days to actually come back. So they knew within about 48 hours versus 5 or 6 days. So this woman, unfortunately, has coccidioid mycosis. So take about 30 seconds, and I want to find out how you want to treat her cocci. All right, let's come back. So just because the students recently took step 1, students, where is cocci endemic? Yes, the people come alive when you ask where cocci is endemic. So southwestern U.S. Where else is cocci endemic? Dr. Kearns just mentioned it. Yeah, so Central and then South America, like portions of South America, that's not geographically accurate, but like Mexico, Central and South America, and then the southwestern US. But just not being from one of those places doesn't necessarily rule it out, but it does decrease your likelihood. Okay, and then what is her risk factor? Great, immunosuppression. In her case, it's HIV/AIDS, and her CD4 count is less than 250, which is like the universally sort of accepted risk factor here. So HIV/AIDS with a CD4 less than 250, or if you've been to any of these places and you have any other more classic form of immunosuppression. Okay, how do you want to treat her? ART, great. So Mike hits the first one, which unlike some of the other opportunistic infections, you want to start these people on antiretrovirals to improve their immune response.
So I have a thought about that. Just, I think we need to rule out, for immune reconstitution syndrome, rule out like do an alpine rule out.
Good question. I might defer that one to Dr. Chan. ID at the time did not have that concern, but I think they talked about it. So I would defer that to Dr. Kearns or Dr. Chan. Do we need to rule out CNS stuff before treating her with ART? If not, I'll look into that myself. Okay, plus minus on that. Katie brings up a great point. What antifungals do we want to give her?
Info.
Ampho, great. And why do you want to do ampho, Mike?
Very.
Great. So if you have severe disease, and the big one here is if you have severe disease with respiratory compromise, then you want to do amphotericin. So essentially, if you are intubated in the ICU, or if you are in the ICU, or you're on oxygen in the ICU, do amphotericin. You don't really have to think too much about that decision. Let's say they're not in that situation. Yeah, itraconazole. So this is one of those times where we use itraconazole. And then the other one that you can sometimes get away with is fluconazole as well. So you can use your sort of your azoles here. So if they're in the ICU, they're very immunosuppressed, amphotericin. If they're not in the ICU, itraconazole or fluconazole. And then ID will sometimes have you do both if they're not getting better. And so in this woman's case, after 10 days, they added fluconazole to amphotericin because she was not getting better. And unfortunately, things continued to get worse, and she ultimately passed away in the ICU. After she passed away, there was a concern towards the end of her life that she may have had another process going on. And so they checked a bunch of labs, including these: an IL-2 receptor, an NK cell activity, a ferritin, and a triglyceride. All of these are abnormal in a very specific way. And what diagnosis does this make you think about? Great, so this should make you think HLH. And so ultimately, she ended up meeting criteria for secondary HLH from Coxie. And so HemOnc wrote a very nice note where they sort of explained their diagnostic reasoning, but she ended up meeting 2 of the 3 things that were pending, the things up here, and they thought that she probably had HLH in addition to her horrible fungal infection. So HLH, they talked about whether they should give her etoposide and chemotherapy, and they obviously decided that the risk probably outweighed the benefit in this case, considering how sick she was. Dr. Kearns or Dr. Chan, any additional thoughts on Coxie here?
I had written in the chat that that I thought that you need a lumbar puncture.
That is a good question. I will look into that. I am not entirely sure. All right. So difficult case, but
I mean, I think that the thing that I reflect on in this case is just sort of the social determinants of health aspect of it. Like, she had maybe been on ART for like 1 month out of her life, and I don't think she had a formal legal status in this country, and didn't know that she was entitled to HIV care. And as a result, this infection that might have been like a viral infection or a mild pneumonia for her if she had an intact immune system. There's people sitting in the room there at Noon Conference who have probably had Coxie, and maybe have a little granuloma in their lung as a result. And this lady died from it. And so I think that was the part that was super hard for us taking care of her. Also, many of her family members had COVID. So even though she did not, she was not able to have family members. And it was just absolutely emotionally brutal taking care of her, for all those reasons.
yeah, this is a really tough case. A lot of our residents were involved in this, and I think all had sort of similar thoughts. Okay, very last case here. This one's the shortest. We've got the blood vessel. Patient brought in by family with vomiting and diarrhea for 3 days, unable to tolerate PO intake, and she is visiting from Mexico. So if you can't already tell, there's a theme to this conference, fungal infections. So she's a 70-year-old woman with HCV cirrhosis, type 2 diabetes. She gets admitted with strep pneumo, really bad septic shock from that. She's in the ICU, she's intubated, she's on 3 pressors, pulse dose steroids, or stress dose steroids. She gets better, she gets extubated on day 10, unfortunately re-intubated day 13, and on day 17, you're called by the nurse while on cross cover for increasing tachypnea and fever. She's got norepinephrine restarted because her MAP was less than 65. So a situation a lot of our interns and residents will find themselves in is being called because someone is febrile in the ICU on cross cover. And so take about 30 seconds to a minute, and I want you guys to tell me your approach to fever on cross cover in the ICU. All right, let's come back. Mark, Min, and Steph, what do you guys think? How do you approach fever in the ICU?
Broadly, so in that order, just to do, so, chest x-ray, check blood cultures, check for urinary tract infections, check for if they're like innovative critical illness or gallbladder, or pancreatitis, or LTCs and lysates, and then usually, hospital-acquired cases and then exceedingly rare, so I think less on that sometimes.
Awesome. So Mark checked off, right, he got the lungs, he got the blood cultures, he hit the urinary system, checking to see if they've got tubes in their mouth, and then looking for like acalculous cholecystitis and sort of more common or more abnormal things that could happen in critical illness. Awesome. Anyone else have anything to add to this framework? Great. So medications, great. So Steph's looking at medications, and then VTE or thrombosis. Perfect. The very last thing I would add, something we don't talk about a lot, but our first case demonstrated this, is the sinuses. And so if someone's had an NG or OG in for a while, could they have some sort of sinus infection or bacterial infection of their sinuses? And then very lastly, there's the T-pain by Mark. Dr. Kearns, I think we can't hear you great right now. And then the very last thing that we should always be checking for, right, is central venous lines. So is there a catheter going in, and how long has that catheter been in for? Dr. Chan or Dr. Kearns, anything to add for fever in the ICU?
Sometimes a hematoma can do that.
Awesome. So yeah, great point. So hematoma or blood where it's not supposed to be can also cause you to have a fever as well.
People also used to say atelectasis can cause fever, but I think there was a paper showing that it does not typically cause fever. I mean, atelectasis is probably one of the most common findings in people hospitalized. They're all lying down, but they don't all have a fever. So, it's low on the list.
Great. Perfect. So sort of in line with atelectasis and what Mark wanted to do, Mark gets a chest x-ray and sees this. We're not going to spend too much time on this chest x-ray, but there are lines, there are tubes, and the right lower lobe is abnormal. This is what the prior looked like, just to show you that there was some improvement here. And so the prior had a much more dense right lower lobe consolidation than the new one. So the intern or the resident, I think, which was actually me in this case, I didn't think there was a problem with the lungs acutely. The next thing we checked was labs, like Mark said. Her white count had gone down a little bit from 4.2 to 2.4. Her platelets were stably low. Her BUN and creatinine were stably very abnormal, but otherwise her labs did not show a whole lot. So last but not least, we get
the atelectasis came from.
No, Dr. Kearns, you're up. Atelectasis?
No, it's all good. So the atelectasis stuff all came from surgical literature that basically when they cut open the viscera and they had a fever on post-op day 1, and then, oh, by the way, they had atelectasis. It was true and unrelated. So yeah, atelectasis does not cause fever. And the one other point about line infections is you can have fever from a line infection and your blood cultures will be negative. So the absence of blood culture positivity does not mean that you don't have a line infection. And so oftentimes we have persistent fevers. The line's been in for, 5, 6, 7 or greater days. Like, you just got to take the line out and start all over again.
Awesome. That is a wonderful segue to what happens next. So her blood cultures come back. And at Denver Health, we have something very nice. We have a very rapid responses for micro, and they detect Candida albicans in her blood, which is susceptible to fluconazole and voriconazole. So before this came back, the team was told that she had yeast in her blood. Yeast in the blood is never a contaminant, so please never disregard that. Always start people on empiric antifungals while you're awaiting a culture. And so this gets a little confusing at our sites, but what empiric antifungal do we typically start in the ICU? Cresemba, and what is the full name for Cresemba? Some words are being said now. Syllabi are being put together. So we typically start an echinocandin at all of our sites in the ICU, right? We typically start either mycofungin or anidulafungin, and this varies by which site we're working at. So here at the VA and at Denver Health, we start mycofungin. I believe at university we will start anidulafungin. And does anyone know why we start these as prophylaxis or as empiric therapy? This question comes up a lot in ICU rounds, but if you have Candida glabrata or you have Candida krusei, both of these are going to be resistant to fluconazole. And so if you need to cover both of those things, you need to have them on echinocandin as opposed to fluconazole or something else. And so that's why we start broad and then we narrow once we get our susceptibilities back.
But this is like, presumably we didn't have this yet, is that what you're saying?
Say it again.
Is this presumably we don't have this data yet?
Yeah, presuming you have this. So that's why when you're starting empiric antifungals in the ICU, you're starting with an echinocandin because you want to make sure you're covering broadly for Candida, all types, which is going to be the most common hospital-acquired fungal infection. So the next question then, the thing we're going to end the conference on is why don't we just give everyone in the ICU an empiric echinocandin? Does anyone know? We talked about it.
Like on Abbott along with your MRSA swab?
Yeah, so MRSA swab, mycofungin, and welcome to the ICU. So there's always a study. So the reason we don't do that and we don't really think about our empiric stuff too much is this study, the Empiricus Trial, which came out a few years ago. It's an interesting study, but basically they took 260 patients and gave them mycofungin or placebo. Their inclusion criteria, they needed all of these, and this sounds a lot like most of our patients in the ICU. So critically ill in event, they were colonized with Candida in the urine, the sputum, on a skin culture. They had organ dysfunction, they were on broad spectrum antibiotics, they had catheters, and they had a concern for ICU-acquired sepsis. Anyone want to take a guess what this study ended up showing? Great, so if we don't do it, it probably didn't show anything, and that is correct. So they found that if you were non-neutropenic, that's the big qualifier, there was no change in mortality or outcome by giving people empiric mycofungin. So that's why in the ICU, you see Candida in the sputum culture, you see it in your urine culture, you change the catheter, change whatever you have to, but you don't necessarily have to start broad spectrum just yet. So very last thing then, when should you be more concerned about Candida? So we're going to go table to table. Each table's got to throw out a risk factor. We'll start here. You guys got it easy. Neutropenia, great. So neutropenia or immune suppression, perfect. Table 2, risk factors. Yes, steroids. There's a trick here. The risk factors are also the inclusion criteria as well, right next to it. Antibiotics, great. So if you're on broad spectrum antibiotics, perfect. TPN, awesome.
Prior infection, prior Candida.
Great, so prior history with Candida.
Lines.
Awesome, lines. And then very last one that we don't see so much is going to be abdominal surgery. So if you're in a surgical trauma ICU or they've had a prior perf or something like that, that increases your risk. But these 7 are the big ones. So neutropenia or any immunocompromised, steroids, antibiotics, TPN, a history of this, you have lines in place, or you had an abdominal surgery in the past. Cool. Any questions about candidemia?
I do have a statement. We had a patient on chronic TPN, and we learned that it's actually a lot less risky now with the new formulas to get candidemia from TPN, which was news to me, so.
Awesome. Do you know
So
what
we
it,
should use a lot more TPN.
Yeah, definitely.
Kate, do you know what it is about the TPN formula?
It's like the formulas, I think it's sterilized better or like in a more thorough way than it used to be. The nutritionist came on rounds and talked to us about TPN for one of our patients and said it's really negligible compared to what it used to be.
Cool. Good to know. Awesome. Anyone additional teaching points? CJ.
I'm just curious, what's the process for exchanging lines if someone has Candida? Like, do you exchange it right away and then like reculture, or do you like wait till blood culture's clear and then exchange lines? Like, what's the sequence?
Yeah, great question. Typically, you exchange the line and then similar to other bacteremias, repeat cultures in like 24 to 48 hours. So do your same thing and see if it clears, which brings up a good point. What other thing do these people need consult-wise and imaging-wise? Echoes, and then you have to call ophthalmology. So this is one of those ICU ophthalmology consults, which Rachel Scott, if she's in here, will be. She ran out before we talked about candidemia. It's too bad. But you want to rule out endophthalmitis, which is less risky now than it used to be, now that we're catching candidemia earlier, but they need an echo and they need an ophtho consult as well. Any additional thoughts, questions? Covered a lot of stuff today. We covered fungal stuff. So we talked about invasive aspergillosis. This MRI brain is going to be scrolling till the end of eternity. But we talked about invasive aspergillosis. We talked about candidemia in an ICU patient who had some indwelling lines. And then finally, we talked about a really bad case of coccidiomycosis in a person who had untreated HIV. Cool. Thanks, everyone.
Thank you.